So scenario one, yeah, each one has a theme that we try to cover. So this one's about consent and capacity. A 60-year-old woman with intellectual disability and a diagnosis of borderline personality disorder lives in a community group home. There's a long history of institutionalization and a significant trauma history dating back to the 1970s. Her life has included lots of movement in foster care and many admissions to hospital or detention centers. She presents with frequent verbal outbursts and can physically strike out at others at times when her needs are not met. She currently has capacity to make her own treatment decisions, but does not have capacity for finances. Recently, she was diagnosed with breast cancer, signed consents, and subsequently had a lobectomy. Following the lobectomy, she was extremely upset by the scarring and claimed to have been tricked into signing the consents. She is now refusing to sign any consents or to follow up with any of the medical recommendations. Although she claims she never had cancer, she remains capable of making treatment decisions. The oncologist is recommending radiation, chemotherapy, oral medications, a biopsy, and likely another surgery. She is refusing all recommendations and becomes very upset when the subject is broached.
So this is the case that often takes up most of the time, and this everyone would talk about, so we're going to keep this one really time focused.
We will. So the questions we're going to pose are, what are the responsibilities of the clinical team and the circle of care supporting this individual? Can you comment a bit on the idea of dignity of risk and capacity, and maybe someone can talk about what that is? And then this idea of persuasion and reward. So some of the strategies that have been used with this individual is something like, if you go to your medical appointment, afterwards we'll go to a chalet or we'll get lunch. And that's been effective, but it kind of calls into question some ethical issues. So I'm hoping that we can start with those questions, and I'll toss it over to the panel. Anyone feel like taking that on for a start?
They're also going to look at this one. So, from a legal perspective, I think the things that jump out at me is this question of capacity and consent. So immediately when I see the line that she claims she never has cancer, that automatically triggers in my mind, is this in fact somebody that's able to make this decision? And does she have capacity to consent or to refuse the treatment? And so that's something that ultimately would be a decision that rests, or an assessment that rests with the oncologist who's proposing her cancer treatments, but is critical that they are receiving information from the community teams and the supports and family that this person has, so that that oncologist has a full understanding of her abilities and her what she's saying about her condition in order to make a fully assessed decision about her capacity. If she is in fact found capable after a very thorough assessment, there's a fundamental right for all capable individuals to refuse treatment, even if that's not in their best interest, even if it could lead to very, very significant critical outcomes, even if it feels really bad right in here. That's an individual's right, and the role of the team at that point switches to how can we educate her and see if we can help her make a decision, and how, if that's her decision, then how can we support her moving forward, honoring that decision that she's making.
Thanks, Kendra. Tom, this is an ethical quandary if I've ever seen one. What do you think?
Well, and maybe I will focus for the ease of time on this concept of persuasion and reward, because it can be an ethical quagmire. So when we think about that, and I would imagine all of you at some point when you're working with patients and clients have engaged these tools. The question is one of degree. So can I encourage somebody to do something that they're reluctant to do? Can I incentivize them to do something that they might be reluctant to do? Can I persuade them? Can I pressure them? Can I coerce them? When do you cross lines? So coercion clearly would be problematic. From a legal point of view, certainly, but also probably from a self-determination and autonomy point of view. If I coerce you into doing something, that's generally seen as a negative thing. If I encourage you or I incentivize you to do something because it's really good for you to do it, and having lunch is the reward, or getting a cup of coffee is the reward, have I done something that is ethically or morally inappropriate? And it's not really an easy question to answer because there are issues of power imbalance. So when I might encourage Kendra to do something, if I had somebody who was extremely vulnerable, that same level of encouragement could well be coercion, because that person is vulnerable and there is a power imbalance. And so how do you, in your own mind, as you're engaging with that person, draw a line around, well, lunch is an incentive, tickets to the NHL, Stanley Cup final game is coercive, right? Because, oh boy, they're gonna do anything I want if I give them the tickets. If I give them lunch, well, they might or they might not, depending on how hungry they are and what they like, right? So how do you do that? When is it appropriate to do it? When isn't it appropriate to do it? And a lot of that has to do with the vulnerability of the individual, the power imbalance that's created, and also the decision that's being made. If it's a matter of encouraging or incentivizing somebody to go to an appointment for a follow-up checkup that they're resistant to do, that's one thing. If it's trying to incentivize or encourage somebody to go to an oncology appointment because they've got end-stage cancer and they might well die, that would look like something else. And so when you are engaging in those activities, it really is a challenge for you to know what level of, because all of these are types of pressure, so what level of pressure to apply, when to back off. And it really impacts the individual's autonomy and self-determination when we employ those tools. It may not always be inappropriate. There may be certain things that would always be inappropriate. And so you've got to try to find a balance, and that balance can be a challenge given the particular circumstances you're faced with. In this case, certainly.
Great, thanks, Tom. Sandy, we often have these, the whole team rarely agrees on whether someone is capable or not. Someone may say, she's capable, I explained the procedures to her, and she said okay, and then went and did it, and then other team members are saying something like, what are you talking about? I asked her, and she said, what's cancer? I don't have that at all. It seems that consent for treatment and for finances can be a pretty fluid thing. Are there resources or support through the Office of Public Guardian to support clinicians in kind of navigating those fluctuating issues of capacity?
Well, in terms of this scenario, I mean, it mentions that she's not financially capable, but that doesn't really have anything to do with this situation. So I don't think there would be, unless there was some other role for us besides this, if she was at risk somehow. But in terms of the capacity to make her own treatment decisions, that's up to the physician who's proposing the treatment to determine whether or not the person's capable or not. If they feel that she's not capable of making her own treatment decision, then they go through the Healthcare Consent Act hierarchy to see who would the decision maker, who that would be. We are on that list, but we're last resort. So once the physician makes the determination that the person's not capable of making their own treatment decision, they go through that list to see who, if it's a power of attorney or a court order guardian or a family member on the hierarchy, and then it would be us, our treatment decisions unit, and they would just call, and basically you call, and then they will have that discussion. The treatment decisions consultant will have a discussion because there may be somebody else out there that actually is on that hierarchy that's higher than us. But that's the only way that we would get involved. I don't know that we necessarily get into discussions around that capacity piece per se when it's something like this, like an actual treatment decision that needs to be made.
So in this case, let's pretend that this woman is found incapable of making treatment decisions and she doesn't have any family.
So then the physician would call our treatment decisions unit, and they would speak to a treatment decisions consultant who would then make the decision, just like any other family member would. They'd get all the information, relevant information, to be able to make the decision on that person's behalf and in their best interest. So that consultant would do that.
So Cindy, there is quite a bit of complexity for somebody navigating services or supporting their clients in the community. And specifically, this brought up for me a question about the rapport with your client when you're supporting them to get the initial procedure and the outcome of that, and then trying to support them to follow up their medical or navigate various services. I wonder if you could just comment on the role of someone within developmental services that's supporting clients and maybe some of the challenges you might face in these kind of situations.
I think in a case like this, I definitely develop a rapport with the client, and I try to help, walk her through this very difficult process. And when I work with complex clients like this, I like to collaborate and surround myself with other service providers in the community so we can all work together. Like specifically on this case, because this is someone who I work with, we connected with a network of specialized care, and we accessed Angie Gonzalez, who's an amazing nurse there, and she supported us. We ensured we used some supports, from CAMH, from the developmental community, from the mental health community. We all came together and we've created this circle of support around this point to help make some of these things easier for her.
Thanks. So I just want to ask one kind of final question here. Tom, you had commented before on this idea of consent versus assent, right? So that even if someone is consenting, that might not be the be-all, end-all. I wonder if you could elaborate on that.
Right. So when we think about this particular case, clearly this woman has felt traumatized post-surgically by her reaction to her scars. And let's say that she's resistant to attending follow-up appointments, but they really are necessary. And there may actually be additional treatments required. And you're working with this individual, and you've persuaded, you've incentivized, you've gotten the person to agree to go to the appointment for, we'll say, a debridement or something, right? We're going to clean the wound post-surgically. So great success. We've got the patient to agree. We've got an appointment set up. We go to the appointment. And what happens when you get to the appointment? She has a fit. And she says, "No, you're not touching me." Is the doctor going to tie this patient down and provide care against their will? Even if somebody's consented on their behalf or they've agreed to it, but once they've gotten there, they've refused. And so one of the things to think about when you're doing engaging around these issues is where are the limits? Because if you've gotten somebody, if you've really worked hard for weeks and weeks and weeks to get somebody to agree to a surgery that's necessary, they show up for surgery and then in the moment say, no, and it happens, right? How are you going to approach that? Is the physician on board? Is the physician going to restrain the patient and provide care against their will, even though it's been consented to by somebody else? And that becomes a real challenge because you may well have wasted all of your time if you get to that point. So it needs to be thought about and considered, and we see that quite a bit. Or in the moment they become resistant, and there's a lot of work that needs to take place in that moment to maybe talk them down, to accompany them, to work with them through the procedures, and that can be very resource and labor intensive. So thinking about are we prepared for how this might play itself out when we get to where we think we want to be going.